Good afternoon. My name is Krista, the Administrator for the Southeast Asia Regional Office of the Association of Academic Health Centers International AAHCI. I'd like to invite Professor Doris Yong from Yong School of Medicine at the University of Singapore, who is the chairperson for today's session, to say a few words. Prof. Young, please.
Good afternoon. I'd like to welcome everyone to today's AAHCI regional webinar. AAHCI brings together academic health centers who share common aspiration of advancing and applying knowledge to improve global health. At Southeast Asia Regional Office, we work on facilitating regional networking opportunities, educational programs, and exchange of best practices. We have for a series of webinars featuring speakers and panelists from different countries in the region. Today's session will include a presentation, a discussion, and a Q&A session will be open to participants to raise questions. It is the second regional webinar, and we hope that this interactive format will continue to engage academic health leaders in the region. So, the webinar topic is on strengthening care through the primary care physicians, and it will be presented by Dr. Dhanasari to share on Indonesia's experience. So without further ado, I would welcome Dr. Dhanasari from Indonesia to present for us today. Thank you, Dr. Dhanasari.
Thank you, Doris Young. Good afternoon, everybody. This is Dhanasari. I represent Faculty of Medicine, Universitas Indonesia, and also represent the Associations of Indonesia Primary Care Physicians. Today's topic is about the readiness of Indonesia primary healthcare advancing universal health coverage on 2019. So all you know that Indonesia is a big country. There's more than 9,000, almost 10,000 primary health centers belong to the government, and another 38,000 are private medical clinics. As for service for 258 million populations. We know that Indonesia faced difficult time to start the universal coverage in 2014. The of universal coverage stated that Indonesia will ensure all Indonesian people. The government decided to start last 2014 for government employees and for people, for full people by today. And what points declaration in 2007 stated that we have to work towards common standards for quality healthcare, education, training, accreditation, and certification to set competencies for general practitioners or physicians. And 2014, we faced a number of referral cases from primary care to secondary, overload in patients and options. This increase. So government have new direction of health development. To ease the promotive and preventive efforts, then efforts. So the topic is independence and fairness of healthy society. 2014, Ministry of Health had regulations regarding national vision for primary health care, that the primary health care is not a medical care only anymore, and not only for selected primary health care, but all primary health care centers should give the comprehensive care. The question is, the care in Indonesia capable to serve comprehensive care. So, topics outlined is 1, the situation of recent primary care physicians in Indonesia, 2, necessity of primary care physician reformation, and is the postgraduate residency program for primary care physicians, and our works as National Board of Primary Care Physicians. This is the situation here. Primary healthcare centers Indonesia, and there are 15,800 medical doctors registered as government employee in primary healthcare, while the council stated there's 120,000 more medical doctors registered in Indonesia. And secondary level, we have 1,733 general hospitals and 420 specialist hospitals. So there are 22,000 medical doctors registered as a hospital employee. The specialists, 30,646 specialists. And we have 17 tertiary hospitals. Well, for now, it's about half of them opened as tertiary hospitals. For the geography, regarding the geographic, the Asia divided by 3 parts: the urban, the rural, and the remote and border areas. So all of them have different characteristics of people, person, or diseases. The universal coverage era is to different system payment. For the care centers, the payment is the capitation payment, and the secondary is reimbursement system payment. We will have the new paradigm. For the we do hope it's more prevention, more patient-centered, more community empowerment, and of course professional care. And secondary and tertiary health facilities, the new paradigm as well. They know standards and have to give the high quality services, and of course they have to give the generic medicines. And of course we have to reform the system of referral and the referral return system. As based on the WHO report, primary levels should be care to awareness of health, should be patient-centered in care, do prevention at all stages, and establishing networking for patients. All these are maybe not so good, so well now in primary healthcare in Indonesia. And necessity competencies of physician in primary care, or its as their character as in the population in urban and remote areas. So there are some competencies that we have to look after. We decided there are competencies of Indonesian primary care physicians. These competencies we after graduate from basic medical education. So they have to able to give the patient-centered and family-focused at personal health care. They have to give the prevention approach at clinical skills, to community and people-oriented at public management, and of course they have to professional at primary care centers. And they have to show the ethics, law and professional at primary care, effective leadership, and holistic and comprehensive communication and culture proficiency. After decided the competent needs of the physicians, we plan to have the postgraduate residency program. So we have the basic medical education for 5 years now. And after that, the young medical doctors have to go internship program for 1 year. And they can be a GP in primary care, or they choose to be another specialist by going the residency program, or not to practice as medical doctor. But we have one more choice. They can choose to join the primary care physician education program for 3 years before they go to the primary care healthcare center. So the situations now, and it registers 120,000 medical doctors. Of course, about the 15,000 then 5 years practice now, because they are just a new grade. And one of them interest to be another specialist. And from the 40%, maybe 60% interest to be the PCP with the postgraduate education. So, estimations about deep interest to have the residency program of PCP. And we have written 105,000 doctors, and 60% of that interview PCP with PG education. So for this already practice for more than 5 years, we have the program of recognition priority learning system. So the program is only 6 months to be PCP. So is only for the time shifting. Okay. Okay, this is the curriculum structure of PCP education program for 3 years. So we have 1 semester for enrichment phase, and this is similar with the nice prior learning program here, the 6 months program. But different material, but the program is similar. And that 2 semesters for the residency phase, but this 1 year is work-based place education, learning, and those practice in hospitals near the working place. And year and half, another 1 year and half is practice phase. So, the doctors who are, so we have a program that doctors who practice in urban go to the rural area, and vice versa, the rural area doctors go to urban area with the experience. In the need of primary care physicians in Indonesia now is about the 90,000 here, but will be increased as well as the increase of the population, of course. And the necessity in urban and rural and remote area are different. So we're planning to have some small area special education, rural and remote. Okay. And then the government have the National Board of Primary Care Physicians to prepare the statutory program. And 19 faculty medicine with 8, and we'll the IAS, and all the members faculty of 19 this, including the board. Okay. This is the essential teachers amount of 19 centers. Have to have the home-based teacher, clinical teachers, and field supervisor at primary centers. And now, until this time, we already make the trainers for the home-based teachers, for the clinical teachers, and for supervisors, about 60% of all total amount. We have already teachers for program initiators for home-based teachers for and establish the standards. Yeah, and we have the training of the teachers for clinical teachers, third centers, and we training of supervisors, training of family medicine approach, of recognizing prior learning program, of the medical teachers topics and annotations. That's all that we have now, and decided to have primary care physicians who took postgraduate residency program as medical health centers as one of service delivery reforms. And medicine who has highest level of accreditation are supported by government to establish the PCP study program. The primary health centers and specific education have already begun, and necessity of the PCP on all over Indonesia are so high, so we need more innovations regarding the to have the amount of the PCPs with the high quality standards, but in a short time. Okay, thank you very much for this opportunity, Doris.
Thank you. Thank you, Dr. Dhanasari. It's a very fantastic and ambitious plan to improve primary healthcare and health services to the people of Indonesia. So we now begin the panel discussion. And with us this afternoon, with Professor Zorayda LEOPANDO. We all sort of know her as Dada from the College of Medicine, University of the Philippines, Manila. And also have Professor Hock from Duke-NUS Medical School. So perhaps I'd like to ask Professor LEOPANDO, would you like to start your comment?
First, I want to congratulate Dhanasari and the National Board for working on this very difficult task. I know how big Indonesia is, how much people you have, and the number of trainers available. Yeah. So, first, when you made a computation as to the number of your trainees, you included only the people who are already in practice for more than 5 years, and the people and the primary care physicians who are in practice for less than 5 years. What about the plans that you have in terms of those who will be graduating basic medical education? Is there a plan to encourage them to become primary care physicians as well, so that the workers will be more?
Okay. May I answer directly, Dr. Doris? Hello?
Yes, go ahead. Yes. Go ahead.
Okay, thanks for the questions, Ma'am Dada. Okay, of course, it's not easy for us. And we decided to, before we decided that there are to the regular curriculum, the RPL curriculum. And the PL curriculum is based on the prior knowledge and experience of the doctor. But if the number is so, then we decided that, okay, the RPL program is fixed 6 months only. So we just decided by 5 years experience and less 5 years experience, more than 5 years and less than 5 years. So the doctor who has experience more than 5 years is he has the shifting paradigm education program for 6 months, and it's so workplace education. It's also e-learning, but sometimes in that 6 months we invite them to go to the hospitals nearest to have the skill practice training. And after 6 months, they graduate. Of course, they have to make the thesis. They have to make the thesis or the EBR, evidence case report. So the doctor already have the graduate in any topics, have experience in making the thesis. There's no pass another thesis, but only the ABCR. But the one who have the experience making thesis, they have to thesis in 6 months.
Okay. So they will, so will continue to work in the Puskesmas while they are undergoing training.
Yeah, and also for the 3 years program.
For 3 years program. Have you included?
They have to still in their place.
Have you included also the 38,000 doctors in private practice?
Yeah. Okay. This for the areas, the government has special allocation for fund for the Puskesmas doctor.
Okay.
But the program itself is not closed for doctors.
Okay. Good. Yeah.
So we make curriculum. It's like other residency program, but we make the curriculum as a residency program who workplace-based education program. So doctors still can work at their place.
Yes.
Okay, maybe if we can pass on to Professor Lee Ken Hock, would you like to make some comment, and then we can have a bit of discussion amongst the panelists.
Yeah, I'm also very impressed, especially by the scale of your program is huge, and I really must congratulate you as well for successfully carrying out this program. So the thing is, I'm also impressed by the very innovative use of existing resources to train this large number of doctors. And I think, but I'm very intrigued by one of this initiative you have that is called a home-based teacher. So can you tell us a bit more about this home-based teacher and how you recruit them into the program to help to teach the large number of doctors?
Thank you for the questions, Professor Hock. The home-based teacher actually it's regarding the regulation of the Ministry of Education, Higher Education here. So every study program, postgraduate program, and all the residency program have to have 6 home-based teachers. So the 6 home-based teachers they have to have the PhD, so PhDs in area, and or they no PhD, but they are specialists who the specialist in some subtopics in the program. So, for example, uh, primary physicians, is, including the family medicine, community medicine, and public health. In our curriculum like that. So the home-based teacher is expert on the family medicine or expert in community medicine, expert in public health. One of them, two of them. The other home-based teachers can be, for example, the interns, the specialist in internal medicine, because the part of the curriculum has intern medicine or pediatrician will teach in a program. So, in our faculty, if we program study program, we have to have 30 home-based teachers who can be assigned another home-based teacher for a program.
So why are they called home based? In what aspect are they home based?
The base of he as teacher in that faculty.
So like belong to any program, but this primary care program, that's home.
But he can teach for the program. He cannot assign as home base for the program. So the six are the manager for this program. They develop the curriculum. They develop the book study. They develop the student book or something like that for that program.
Yes.
The other point I'm interested in is how do you motivate the doctors to take up this program? In Singapore, for example, we created the Family Physician Register, and this motivates many of them to take up this program so that they can be on this register, recognize their increased competency in the discipline of family medicine.
Yeah. First, we promote that our program is increase the level, so they are same as high as other specialists. So the primary care physicians is under the specialists because they are graded as basic medical education doctor. So they join the PCP program. They increase one level, so that's same with other specialists. So see that. Definitely, for the government employee, it's need for to of course. For the medical doctors in Puskesmas, how to can have the promotions, they take the magister program in public health, magister program in nutrition, and magister program in any subjects. But actually, they need the program that the necessity of to be the physician with it. So that's the correct program for them.
Thank you. And this is a very important point that the student is recognized as being equivalent to specialists.
Yeah. Can I have another question?
Sure, go ahead, Dada.
Yeah. I noticed in the diagram a lot of portfolio assessment will be done. In fact, it's from semester 1 to semester 6. Who is going to do the portfolio assessment for each year?
Yeah. We assign it with the comparison, one for every three participants, trainee, we have one trainer for assessment. One will be the home-based teachers and the clinicians. That's why we ask the clinicians to be the clinical teacher for this program. So, yes, yeah, and of course, special training for that.
Okay.
So every we have to have 6 and 15 clinical teacher, and of course 25 field supervisors. The field supervisors, actually, this is another PCP who has graduated before. So before they graduate, the clinical teachers and home-based teachers is the field supervisor. But we have around 200 something who graduate from the PCP program. So they are the field supervisors.
Okay. They're going to do the assessment from Semester 1 to Semester 6 if they decide to complete the program.
Not the field supervisors, only the home-based and
the home-based.
Yeah, home-based and
home-based.
Clinical teachers.
Clinical teachers. Okay. Yeah.
Okay. What we'll do now, we can always come back and continue the discussions, but I thought we might now begin a Q&A session. And for those of you who have logged on to participate in this webinar, can you please remember to submit your questions, either use the chat box on your screen. Otherwise, you click on the hand icon on the right panel to indicate that you would like to voice a question. So I'll let question, yep. And so, Angelina. Enter. Angela. You. Here, so maybe come to you later. Any got a question? We're just trying to look at the hands. Yep. Is it looking at that? Is that Retina? Yep. Retina, can you yep.
Yes.
Go.
Yes. Can you hear me?
Yes, yes, we can.
Thank you very much for the opportunity. Hello, Dhanasari. Very nice to hear you here. But actually, I would like to ask the question. It's not for Dr. Dhanasari because I and Dr. Dhanasari is already discussed about this program many times. But I would like to ask your opinion, especially a colleague from Duke and from Philippines, about some information about how do you do it in your own country, or have any experience or information about any other countries who's trying to develop primary care physician in the country. Example, what obstacle do they have? And do you think that our program is having high probability to be success?
Okay. Who will go first? question, isn't it?
Okay.
Go first.
Answer first. Okay. In the Philippines, we have a training program in family medicine, and they were supposed to be at the front line since 42 years ago. But the kind of training that we're giving is evolving. The advent of universal health care, there is now a need to make sure that all the Filipinos are covered, especially the poor. So what's done is that there is a mechanism by which the poor enroll in a health insurance program with a premium paid by the government, and they'll be enrolled for their primary care benefits in a primary care facility. We are making some innovations in the training program in family medicine in such a way that we will be able to do some retraining for the government physicians who are already serving in the front line. It is ongoing now, but I know that you are kinder to those who have been in practice for a long time because you're giving them 6 months as re-entry. Yes, we are giving them actually a month, a year, and can proceed if they want. They can stop if they want to stop primary care physician level. If they want to be considered specialists just like you're doing, we are going to have additional 2 to 3 training. Yeah. We have foundation courses that are being offered to them. They are in the government to make sure that there is integration of public health and clinical medicine training. Yeah. So doing that, we are hoping that IQ we can encourage academic programs to adapt a province. For example, and university already adopted one DOH program, and they're going to train the health center physicians. We are also, the University of the Philippines is also adopting one province where all the health center physicians will undergo the practice-based training. And we will also have district health physicians to undergo training also. The health source in the DOH would like to have an integration of the clinical and public health also, going into district hospital exposure for municipal health officers.
Okay. Perhaps for the time, we've got a number of more questions. So, Hock, you want to respond about the Singapore situation?
Very quickly, the Singapore system, we started having residency training, which is the 3-year program. We were 2 years in the hospital and 1 year in primary care, way back in the 80s. So we have this, and after completing 3 years, they can do an additional 2 years where they realize as having attained advanced specialist training in family medicine and be awarded the fellowship. The program is very rigorous and inclusive, but the we have is the limited resources. So as a result, we can only train rather small numbers of doctors to attain this level of training. So around year 2000, we realized that we, just like as in India now, we realized that we need to train large numbers of family physicians. And even like when we talk universal access to healthcare, we are talking about universal education for all doctors entering family medicine. So about 60% of them actually become specialists. The rest, we hope to be able to train them. So we decided that we need a mass education program, which created a graduate diploma in family medicine. It's a 2-year program, accessible by both people who work in institutions as well as those in private practice. And over the years, we have been pushing for this. And by 2011, we decided to encourage even more to take this up, and hopefully have universal coverage of all doctors by perhaps 2020, maybe. We have this program, and we are moving towards having all family doctors to have this minimum standard of training that we have created. So, in a nutshell, what we have done so far.
Thank you very much to Ken Hock to give a Singapore perspective. We've got another question from Harold Mantara, and then we can go on to a type question which I will read out in a minute. So, Harold, your turn. Hello.
Presentation, Dr. Dani. I'm May from UGM. I would like to ask a question not related to this training program, but I would like to ask what the role of a physician in terms of academic health system. Maybe the panelists can also give answer of my question. What the role of family doctor in terms of academic health system?
Can you hear the question?
Yes.
Academic health.
Yes.
The academic health rule.
The role of the physicians, the PCP in academic health system, is it? Is it,
Right.
Dr. Haryo?
Yes.
Yeah.
Anyone want to respond to that?
Can I respond first?
Okay. In the Philippines, family and community medicine is one of the courses included in basic medical education. So it is important that there is someone trained in the discipline to teach students for medical degrees. This part is one of the courses in community medicine. And the one is the Philippines, as much as possible, we also consider family physicians as primary care doctors. In the World Organization of Family Doctors, they are used interchangeably. Doctor, family physician, doctor physician, and general practitioners in countries where they call them GPs. No, so definitely, because part of the medical curriculum, there is postgraduate training. So family physicians who are trained to be teachers as well will have a role in the academic health system. You have a question?
For example, the teacher of this program is also belong to the faculty or also non-parties?
In the Philippines, we have a department, academic department in the medical school, clinical department in the hospital, within the academic health system.
And the teacher from the primary care setting?
Because all required to have to have a community health program working with the local government unit where we can send our students for training in the community, not only in clinics but also in doing community work and working with the people there.
Right. Thank you. Ken Hock, you want to respond to that for Singapore?
Yeah. So in Singapore, our academic medical centers are all have an affiliated medical school. And all these schools, there's family medicine department and academic department. Faculty are largely either full-time academics or they are practicing clinicians. And they both work together as part of a larger faculty that is contributing to the education of family doctors. At the medical school level, as well as in the residency, as well as the advanced specialist training program. So in a way, you will find that many of the practicing clinicians actually have adjunct appointments in the academic departments of family medicine. And we have a regular rank of academics working in the medical school. So very integral to the academic matters actually.
Okay, I'm going to go back to so that we can get the other back. No, it's gone. So anyone else got any questions? So I can question. Okay. So I'll just read that out. This question from the participants. Do other practitioners gain any benefit to pursue postgraduate training? This is from the view of from Dhanasari. I don't want to answer this, but perhaps we can around. So do private practitioners gain any benefit to pursue postgraduate training?
I think the number, can I do that?
Yes, go ahead, Ada.
The one benefit that they can get will be the updating of their clinical knowledge, because we all know that sometimes forget to attend to their continuing professional development. Entering postgraduate training will fully develop this attitude towards lifelong learning. So that's one of the benefits. Second is the recognition that he will get, because if you undergo postgraduate training and have the qualifying examination for the specialty, then you can be considered a specialist. And if already considered a specialist, then you can engage into, in addition to your practice, you can be part of the academic world, you can do research, and you can do some leadership role in organizations. I think those are just some of the benefits that you can get if you undergo postgraduate training.
So in
go on, Ken Hock.
So in Singapore, the doctors in practice, of course, not require any postgraduate degree for registration or promotion in academic rank, even say in institutional rank. Of course, those in public sector will have this benefit. So, but luckily the same is that many of them are motivated by the opportunity for professional development. And as I have said, some of these people in practice actually hold academic appointments as well. So they are recognized for that additional degrees and qualifications. Now, the thing now is recently that's happening in Singapore is that government is actually recognizing people in private practice with additional qualification in family medicine. So the programs that we run will give special recognition for doctors with recognized qualifications in family medicine. They get to participate in government-run programs. That again acts as an encouragement for such doctors to take it up.
Okay. What about in Indonesia, Dr. Dhanasari? What would they bother the private practitioners to do that?
Yeah.
Money?
Because there are no regulation of fees of private sectors, so it's depend on the doctors, of course. But for the capitations, because this faces the universal coverage, so the primary care physician will have the capitations payment, is it? So the government's already counting that the PCP who already trained as PCP will have the increased capitations amount.
Okay. Right. So we go on to the same question, and you can volunteer to answer that. Is home-based, I guess it's Dhanasari really, Indonesia, is home-based and innovative residency training? Does it differ or detract people from practice-based residency training?
Okay, actually the innovative residency training is not the home-based, but the workplace-based education.
Okay.
This education. So the home-based is the home-based teacher, is it?
Yeah, it's not. It's just, it's not a special residency. Okay. Now, I'm dying to ask the third question. The question is really about the patients. I think winning trust from the public is everything to that sort of program successful. So we can do all we want. Will patients actually go to those doctors? Will they recognize them? And the patients then have to pay more if they start the private GP with PG training. In other words, there's a differential payment. Or agencies provide funds for them. I think it's a very important question. Anyone can take that on? Maybe you go first, because you're going to introduce this higher tier of GP training. So how do you think the patients, how would they respond?
Yeah. Firstly, there are that the PCP with trained will be more expensive than GP without training. But after I know that we paid by the capitation, so it's the money is not from the patient, so it's from the system of universal coverage system.
Okay.
Then for the government who has the system in the universal coverage, they think it will be less cost with trained of the GPs, because the rest number without. So it can be decreased the rest of numbers, the patients. So it will be less payment for all the system. So something like that. So it will be increase the payment for the GPs who already take the program.
Are there any differential payment? I guess in Singapore, Kheng, Hock, or in the Philippines, are there any differential payment for GPs with postgraduate training?
So, if I answer for the Singapore perspective,
yes, please.
It is quite right. We really need to educate people to appreciate that what this training brings to the benefit to the patients. For very simple and uncomplicated cases, it's very hard to discern the difference between a doctor advanced training or just a doctor with an ordinary medical degree. And of course, to be fair to those who don't have advanced degrees, they can be just effective, even like that they are doctors who keep up with the CME and so on. But by and large, I think people feel the difference between doctors who have additional training and do not have. And we have from the doctors who took up the course, and they say that they feel that they are more confident to take on all complex cases and so on. Of course, when it comes to paying extra for the additional training, it becomes very sensitive to the point that sometimes very cost-sensitive policymakers even feel that by encouraging additional training, you may escalate the healthcare costs, which of course I think is very unwise. There's a perception in some parts of bureaucracy actually.
Yes. Okay. At the time, I think if Dr. Dhanasari, can you quickly answer the last question? Is there a difference in getting license for the practice between the Gs with postgraduate training and postgraduate training, as you did this for Indonesia?
Until now, it's not. It's license. Primary, yeah. Primary.
License. Good. Quick answer to the question. So I think the time, there'll be other discussions, but I think you can pick it up in the Wonka Asia in Pattaya, which will be a fantastic seminar for us to present from the Asia Pacific. I can think of a fantastic seminar that we can all discuss this. So there are I know there'll be further questions, but I think we need to conclude the AAHCI Southeast Asia Regional Webinar. I would like to thank all the participants and to Dhanasari in particular for preparing these wonderful slides, Professor LEOPANDO, Professor Lee for their presence, and thank you to everyone who took the time to join us online. So what I'll do now, I'll pass on the mic to Crystal, the Regional Administrator, to make a few announcements. Please, thank you, Crystal.
Thank you, Dr. Doris. Thank you.
Yep, go ahead.
So for institutions who are currently not AAHCI members yet, we would like to share with you that we provide support to members as they educate the next generation of health professionals, conduct medical research, and provide patient care. The services offered by AAHC and AAHCI includes meetings with leaders in person and online, both in the U.S. and internationally. Applications and resources are shared with the members regularly, and we represent a global network of academic health center leaders that facilitates opportunities to build new relationships, consultations, partnerships, and collaborations. Info on membership with AAHCI, please visit www.aahcdc.org. And we will be having our Southeast Asia Regional Meeting next year in 2018 at the National University of Singapore on 11 January 2018. The meeting promises to be informative and stimulating and will enable AAHCI members to network with peers from Southeast Asia and around the world. We will analyze and discuss issues faced by academic health systems and centers, especially those in Southeast Asia. This meeting is being held in conjunction with the annual Asia Pacific Medical Education Conference APMEC, which is from 10 to 14 January 2018. The APMEC has seen participation from many medical and healthcare professionals from not only the Pacific region, but also from around the globe. It is timed so that participants can attend both the AAHCI Southeast Asia Regional Meeting and APMEC. I hope you enjoyed today's session, and we look forward to your participation at the next webinar in November. Thank you.
Thanks so much.
Thank you, everyone, and good night.
Good night. Thank you.